Welcome everybody, this is Yasser Wasifi from Learn Dental Series. This is episode we will continue our topic of diagnosis and treatment planning in operative dentistry. We are still focusing on diagnosis of dental caries. I would like to declare that I don't receive fees, compensation or royalties from the sales of any of the products shown or discussed in this presentation. Also, this presentation has not been sponsored by any company, agency, or organization and is only prepared for educational purposes. Let me remind you about this presentation. It is a copyright presentation that could not be transmitted by any means unless you have a written permission from the author. In this presentation today, or in this episode, we are still continuing to correlate between the oral and dental clinical findings and the proposed treatment plan. Also, still we are trying to properly diagnose dental caries by different techniques to diagnose the early and as well as the late progress of dental caries. Okay, in previous episodes we already discussed Part 1 patient assessment and information gathering in terms of demographic data, chief complaint and its history, medical history and dental history. Then in the second part, we already started the clinical examination. We start to examine dental caries. Still, we are within the traditional techniques to diagnose dental caries. In traditional techniques, we started with visual examination, and still we have some topics that untouched up till now and undiscussed up till now. We already discussed the visual examination simply by light and mirror, okay? And then we already assigned indices to help or to score the standardization of visual examination to be more subjective and to decrease the gap between the transformation of what you have seen between operator and another by introducing different indices including BOFA system, including ICDAS system, including American Dental Association system in all aspects, and that's just for standardize the scoring of visual examination. Then today we will continue, okay, how to introduce techniques to improve visual examination, the visual detection of dental caries in early stages rather than naked eye, or to help your naked eye sight view, okay, to determine exactly or detect exactly the presence of dental caries at its early stage. The simplest technique, advanced technique to advance visual examination is the magnification, okay, to allow the practitioner to observe the finest detail with great accuracy and high resolution. This magnification can be achieved by different techniques, including transmitting the vision field, okay, into a monitor with magnifications just like that of intraoral cameras that allow zooming, okay, and aided with light emitting diode light source that will allow you to properly inspect by vision your lesion or your field. Also, magnification loops is available with different magnification up to reaching for microscope which provides you with 20x magnification powers, okay? And here in this table you could find how much the resolution could be improved by using magnifying aids, okay? And each type of magnification, each power of magnification, how much it will improve the resolution of the field you could see, okay? This is an example of intraoral camera to the left side transmitting the field or the picture to a monitor, okay, that could be zoomed and with much better lighting. At the same time, you have a monitor to discuss the case with your patient. It provides much more communication with your patient because of this monitor, okay? To the right side, what we have displayed before in the previous episodes is a magnification loops either with overhead light or not. Okay, this is another way which using microscopy, which is much more important in endodontics, much more than that for optic density. It's also useful and helpful in optic density, but it is commonly used with endodontics, okay, because it is beneficial and its economic visibility, from the visibility of economic part, okay, it is much more beneficial than used it in operative density. You could diagnose, even as you could see in the right side, you could diagnose even micro cracks, okay, and full details of the cavity margins. Then comes what is called trans-illumination. Trans-illumination, it is a source of light, okay, uh, from the buccal or lingual side of the tooth, and on the other side you will have your mirror, okay, just passing the light through the anterior teeth or the posterior teeth from side to side. The proximal caries could be appear as a dark area even if it is incipient, and it will be shown at a darker area. It will help you to diagnose incipient caries in proximal areas. It's as simple as you have a light source from one side and a mirror to receive the image, and just notes the darkness as appeared in this photograph. Then you could perform trans-illumination by two types. Either simplest one is fiber optic trans-illumination device, which is called FOTI as an abbreviation, or the digital version of it, which is called digital imaging fiber optic trans-illumination device, or DI-FOTI. From the terminology digital imaging, you could expect that the image is digitally transmitted to another monitor and could be digitally or by your software, could be manipulated by a way and another to add certain benefits from the software. The idea is very simple, okay, where light is presented through a small aperture in the form of dental handpiece, okay, that shines through the tooth surface, showing caries defects. It's as simple as that, okay. Depending on that, the detection technique, okay, of the caries enamel, okay, depending on that, caries enamel has a lower index of light transmission than sound enamel. That's why when light is absorbed, okay, through the tooth structure, it will be more absorbed when demineralized process disrupts the crystalline structure of enamel and dentine, and that's why it appears more darkened, because the demineralization absorbs more light. This method of caries detection uses a light source, preferably to be much more bright to eliminate your tooth. Caries or demineralized area in dentine or enamel will show up as a darkened area with this technique. This effect can be achieved with a fiber optic illuminator, which is readily available at the handpiece coupler, okay, of your dental operator, normal dental units, and has been used for detection of approximal and occlusal surface as well. Posterior approximal caries can be diagnosed with the light probe positioned on the gingiva below the cervical margin of the tooth, whereby the light passes through the tooth structure and the approximal decay produces a darkened shadow. It's as simple as that, okay? Although this device has the advantage that the examination is done with an operating light source already available in general practice in your unit, okay, it is only useful for approximal and occlusal lesions only, okay. Its sensitivity and specificity are not sufficient for detection of a very early caries lesion, okay, incipient lesion, okay, but much more earlier could not be detected, okay. Beside of that, it is not a quantitative method that I could score it or give it any score, okay, to be useful to monitor your caries over a time. That's it. It just improves the visibility of incipient caries in proximal inaccessible areas. This is the fiber optic trans-illumination device, okay. You could use only the handpiece with the coupler in your unit, okay, just to inspect occlusal and proximal as shown in A and B photographs. Adding a digital component to your FOTI, okay, is a much more beneficial option in your trans-illumination as a device used to detect early dental caries. Not only that during our discussion we will discover that it will add as well as quantitative scoring of your dental caries. Okay, it is not only used to detect dental caries, but also it detects fracture, it detects cracks, it detects secondary caries, it detects any cause of demineralization. It could quantitatively and qualitatively count any demineralization or any defects in your tooth structure and calcification of tooth structure. Okay, it uses the same light of trans-illumination, okay, to trans-illuminate the tooth and instantly create a high-resolution digital image. Okay, this is based on the principle that also carious tissue scatter and absorbs more light than surrounding healthy tissue. That's why decay near the imaged surface appears as a darker area against a more translucent healthy tissue or brighter background of surrounded healthy anatomy. The device just composed of a fiber optic illuminator in a mouthpiece, okay, that delivers light to one of the two surfaces. As the light travels through the layers of enamel and dentine, it is scattered in all directions toward a non-illuminated surface in the opposite side, okay, and the light is then directed through the mouthpiece to a miniature electronic charged coupled device camera in a handpiece, and the camera digitally images the light emerging from either the smooth surface opposite to the illuminator surface or the occlusal surface, okay, and transmitted it to be processed via the software present there. Then your mouthpiece will have two sides, okay, one is the illuminator and one is the surface that received the scattered light, okay, passing through the tooth, and this scattering differs from healthy and unhealthy tissues. That's why it could be transmitted into a charged coupled device, that camera with a charged coupled device that will be digitally transformed into your CPU, and you could process it by a way or another. Decay or caries near the image also appears darker, again is more translucent and brighter background of healthy tissue, as we discussed before in the fiber optic trans-illumination. Okay, these images are then displayed on your monitor in a real time and stored on your hard drive for easy monitoring and follow up the case by comparing the images before and after. Image acquisition could be performed and controlled by software and just a foot pedal. Just you are in need to hold your mouthpiece, okay, and by the foot pedal you could click on it and to get different images. Every images are viewed in both clinician and patient side by using a large monitor with high resolution, and this is useful in patient education and motivation and sharing the patient the condition. Let him imagine to what extent the destruction or to what extent the caries is hidden in inaccessible areas. One of the advantages of your software of this device is the average mineral loss calculation and comparing between normal and abnormal tissue. Okay, this device, by the help of this device, the average mineral loss of tooth structure can be determined by analyzing and recording images and assessment of optical thickness between different thickness of tooth structure of healthy and non-healthy tissues of the same tooth and at different levels and at different times. So it is considered as a qualitative and a quantitative diagnostic method for the lost tooth structure. This is the mouthpiece, okay, and illustrating where is the illuminator side and where is the non-illuminated side, okay, and this is the monitor, and you could share your patient identification to identify and detect, okay, he could imagine how much is the destruction of his teeth. The right side schematic diagram showing that from the illuminator side or the light source side, okay, the light passes through the tooth structure, refracted, reflected, and transmitted, okay, and This is the scattering of light, except for the area of defect that scattered in another way, okay, helping you to view a photo, okay, for this lesion which appears darker than normal healthy tissues. We could inspect these resultant photographs or captured photographs by the dye photo, where in the upper left side you could note sound proximal surface from occlusal, buccal, and lingual views. The lower left side you could showing the difference in darkness in caries proximal surfaces from occlusal, buccal, and lingual views, but which is much more obvious and clear and much more descriptive photograph is the one to the right for caries occlusal surface. This could illustrate to you and your patient the caries lesion, its presence, okay, and its detection. Okay, advantages of dye photo, including its superior sensitivity over traditional radiograph, and can detect early lesion, because later on we will discuss that radiographs could not detect lesions unless it will cause at least 40% demineralization. Less than 40% demineralization could not produce the required visible radiolucency to be detected in radiograph. But here in dye photo, the sensitivity is much more accurate than that for radiograph. Also, the image could be produced faster. Okay, just you are clicking your pedal, you could get much more frames, okay, than adjusting sensor and holding it. It's much more easier for you and your patient. In expense of no radiation, and the safety is much more higher. Okay, but still it couldn't differentiate between caries lesion and hypermineralization and deeply stained fissures or even cracks. Okay, it doesn't show the depth of the lesion, because light is scattered and accumulated or collimated to the non-illuminator sides in 2 dimensions. You couldn't get an idea about the third dimension. You couldn't get an idea about the progress of the lesion. Diagnosis is completely also based on the observer, okay, not the computer assistance, okay. It is just comparing between old and new picture, but it doesn't score this demineralization. But it, as it is archived in your computer, you could compare between before and after, and between in different time intervals. Those all about visual examination. We already discussed the idea of traditional visual examination, how we standardize it with indices, and how we advance it with either magnification or trans-illumination. Trans-illumination is either just fiber optic or digital imaging trans-illumination. Let us move to another technique for detecting caries, is to touching caries. It is the tactile examination of dental caries. Tactile examination of dental caries, as stated by G.V. Black in Operative Dentistry book published in 1924, okay, he stated that a sharp explorer should be used with some pressure, and if a very slight pull, which is like tug back action, is required to remove it, then the spit should be marked for restoration, even if there are no signs of decay. Then he depends only, okay, in a tug back action felt due to slight resistance of the movement of sharp explorer along the bits and fissure, and that's all. Okay, this is how he examining the surface, depending on the surface texture and surface discontinuity, which may be false discontinuity. Okay, and the catching with sharp explorer, he stated that it indicates caries lesion, and even if he is wrong, this lesion or this bits and fissure is susceptible to caries, and you are in need to cut it into a cavity as a mean of extension for prevention, which is nowadays not applicable at all. Okay, and already manufacturer designed different shapes of explorer to provide more accessibility to different areas. Okay, including cowhorn sharp explorers, including also using nowadays unwaxed dental floss to be passed through the contact and if it is come threatened, then it nets a sharp area of your proximal surface that tearing it, indicating that there is a proximal caries. The most famous world explorer, okay, was Marco Polo, Christopher Columbus, Pedro Alvarez Cabral, Fernand de Magellan, Neil Armstrong, and one of the most famous explorer is number 23 explorer, dental explorer. It is more famous than all of these explorers among dentists, okay? And it could take different shapes, either angulated, curved, contra-angled, another curved one, cow horn, to detect the proximal caries, okay, as seen in the middle figure, and you could use unwaxed dental floss, okay, to pass it interproximal. This will allow you not only to examine the proximal area, okay, and present it for detection of caries, but we used it also as a tactile examination of the tightness and the integrity of your contact area for direct and indirect restorations, and also you could use it to examine the presence by tactile sensation, to examine the presence of overhanged margins or overhanged cement when cementing indirect restoration. But when examining dental caries, this dental floss should be unwaxed, because the wax heals the threatening, okay, or heals the tearing, that we could not inspect your dental floss, okay, if it is teared due to meeting sharp edges or rough surface of proximal decay, okay. But for examining proximal contact, or for examining or to remove overhanged margins, to examine the presence of overhanged margins, it is better to be waxed to allow easily and smooth slippage of it along the contact without damaging your restoration, especially if it is amalgam, which requires at least 24 hours to reach its complete setting, okay. Considering the using of explorer especially, many studies recommended not to use sharp explorer at all, and the drawbacks of using it is much more worse than its usefulness in detecting dental caries. This is an old 30, at least 35 years old study, okay, titled Light Microscopy Style Study of the Effect of Probing in Occlusal Surface, okay, stated that traditional use of sharp explorer, okay, is a questionable matter in determining dental caries. Why? Because this catch in diagnosis caries in bits and fissure, okay, should be discontinued by clinician, okay, and just use sharp eyes and blunt explorer, because even it is non-cavitated, it become cavitated by the damage created by this sharp explorer, okay. Another thing, who said that, okay, that this catch is due to discontinuity of the surface, okay. It may be due to friction between fissure with parallel walls with the sides of your explorer, okay. Even penetration by sharp explorer can actually cause cavitation in areas that are starting to remineralize, okay, or in areas that could be remineralized but you already damaged it, okay. Also, forcing sharp explorer by this not only traumatized your enamel, but also may force cariogenic microorganism to be encrypted into your enamel, and while it couldn't, or it is not able to produce, still not able to produce dental caries, you already give it a greater chance, okay, and give it the chance to produce dental caries. And this light microscopic study, just a light microscope showing this damage, okay. A case to the left one, A, is just a fissure, okay. Once you are exploring it with a sharp explorer, okay, you could note the damage, how it comes to your enamel. And another case, okay, if you move it lateral, the damage extended to the lateral wall. This is just a light microscope study, okay. In another Scanning electron microscopic with much more magnification, effects of dental probing on occlusal surface, okay, a scanning electron microscope in much more recent study in 2007, okay, just you could note how much is the trauma caused, okay, as the arrow pointed to by your sharp explorer, okay, and you could note how the walls are parallel to each other of the fissure in the photo to the left side, and inside this square, these are the scratches created by forcing explorer, which is diagnosed as catching or tug back action, which is diagnosed as Caries lesion, while it is absolutely sound, but you felt tug back due to friction between the side walls of your explorer with the side walls of this deep fissure. Another one with higher magnification, showing how much is damage, okay, in both sides of your fissure. Another one showing the damage of your sharp tip of your explorer, and how it is not only breaking the interprismatic substance or breaking your enamel, especially your fissure, okay, is also considered as a weak area because the thickness of enamel, it is improperly coalesced loops, and the thickness of enamel is very thin at this area, okay. That's why it is vulnerable for damage and vulnerable to create cavitation, which is previously not the condition before you are using the explorer. This is the hit injury of the tip of the explorer inside enamel. Another one showing you how much the friction and how much it forces the fragments of enamel deeper. Actually, it will force the enamel, okay, fragments of enamel, and with or accompanied also with cariogenic microorganisms and different types of microorganisms. Another hit, okay, of the head of the sharp point of your explorer, okay, with probing marks, okay, on the sides. That's why most cariologists and epidemiologists recommended the evaluation of presence of discontinuity of enamel, okay, or microcavitations by the use of WHO PSR probe, which is ball-ended one, as we mentioned before when using it in tactile examination, okay, with sphere about 0.5 millimeter, okay, in its extremities or in its diameter, okay, allowing this kind of evaluation by this will be much less aggressive and much less harmful to enamel, and it is also graduated. It is used with periodontists and with epidemiologists and also cariologists because this ball blunt end prevent this explorer from penetrating either soft or hard tissues even when you are exploring the depths of periodontal pocket. Finally, those are the textbooks I used in preparing this presentation. Please feel free to ask me at any time, as your questions are welcomed. You could ask any inquiry by commenting to this video and I will reply to you as soon as possible. Also, you could email me and I will reply to you as soon as possible. Finally, thank you for assigning this time to listen to me. Please don't forget to subscribe to my channel and activate the notification to get all the updates. Thank you. Yasser Al-Wasif.